Hi everyone, we are talking about dermatologic disorders this week, and the lectures have been separated into two parts. So we're going to begin with the first part. It's a total of 38 slides. I'll try to go through this as fast as possible. Just a quick brief review of anatomy and physiology. It's a good cross-section of the skin there. You can see all the different layers and the hair follicles. The epidermis is the thin outer layer. There's 5 layers of stratified squamous epithelium. The keratinocytes comprise most epidermal cells, and melanin is produced in the basal layer. The dermis is the thick middle layer and has important functions for our whole body. It regulates heat loss, it provides host defenses, and it aids in nutrition and regulatory functions. And then the subcutaneous layer consists primarily of adipose tissue. This contains arteries and arterioles, which helps in thermoregulation. So the skin is the largest organ of the body, and you can see it has many functions besides just, cosmetic. And so whenever there's an interruption in the skin integrity, depending on how deep the interruption is, you can see that some of these functions are going to be altered. And you want to make sure that you consider that when you're managing skin conditions, thinking in terms of not just whatever the problem is, but what function of the skin has now been interrupted. So there are some changes that take place in the skin over one's life. And you can see in newborns, the skin is very thin. The epidermis is loosely bound to the dermis, which can cause separation of the layers with blistering. The eccrine sweat glands function, but the apocrine glands do not function yet. And less melanin is present at birth, so skin is lighter colored, and babies do get darker as they get older. And then in contrast, look at adolescence. The skin thickens. The epidermis and dermis are tightly bound. There's increasing resistance to infection and irritation. The eccrine glands achieve full function. After puberty, males sweat more than females. The apocrine sweat glands mature during puberty, and that's what contributes to body odor. Melanin is at adult levels, determining skin color and serving as a shield against ultraviolet radiation. So when we think about how this gradual maturity of the skin, we want to think in terms of the younger the child, the thinner the skin is. We have to keep that in mind when we're prescribing topical medications, that more of the medication can be absorbed through the skin in a younger child. And that's why a lot of products, topical products, are recommended not to be applied on infants less than 6 months old. There are some things that we should take into consideration that are unique to individuals with dark skin. They have different cutaneous reaction patterns. They are more prone to develop hypertrophic scars, which are known as keloid scars, and they can be problematic for cosmetic reasons, and so we need to be concerned about that whenever we're treating a patient with dark skin. There are some normal variations and some common problems. The color and texture can vary from one part of the body to the other. The pigmentation of mucosa and nails does correlate with cutaneous pigmentation. There's increased melanin in thicker skinned areas. And we've talked about, you've certainly heard about in previous courses, hyperpigmented nevi, or the older term Mongolian spots, in darker skinned individuals that are usually present. They're sort of increased deposits of melanin in the skin, and they can be seen on the buttocks, ankles, shoulders of newborns. And then cafe au lait spots can be more difficult to see. The normal exfoliation process in darker skinned individuals produces grayscale. So if you see those, that's normal. Color alterations in the skin are more difficult to assess. Erythema may actually appear as a purple tinge. So you have to be very careful when you're assessing the skin in a darker, in a patient with darker skin. They have tightly curled hair that tangles when dry and mats when wet, which can interfere in examination of the scalp. And atopic dermatitis with pityriasis alba and post-inflammatory hypopigmentation. So with darker skinned individuals, sometimes there is loss of pigmentation as part of the healing process, which will gradually return. In terms of moving on to assessment of the skin and subcutaneous tissue, as always, in our assessment, we begin with history. We want to remember all the key points that we want to ascertain during a history, the onset of the problem, how long it's been there, how did things look in the beginning and how do they look now. That can be very useful because in some problems there's an evolution. An example is, say, chickenpox, which begins as pink papules, and then they evolve to a fluid-filled blister, which then erupts, becomes umbilicated, and crusts over. So just talking about one viral skin problem like chickenpox, there is a variety of types of lesions, and they change over time, so it is important to ascertain specifics. You also want to note if there's any other symptoms. When we talk about some of the skin disorders, some of them can cause systemic signs and symptoms. And if there are associated systemic symptoms, it can change our management of the patient. For example, a skin infection, we might be able to treat outpatient, but if there's evidence that the infection has begun to spread or there are associated systemic signs, we may be more cautious with treating on an outpatient basis and may want to treat the patient in the hospital. We also want to make sure that we've assessed any exposures. There are certain skin problems that are contagious. There are certain skin problems that are the result of exposure to either allergens or plants or other things in the environment, sunburns, etc. Skin can often be where allergy manifestations appear. So even if the allergy is not skin related, we can see the results of an allergy on the skin. So the skin is often or sometimes a window into what could be going on inside the body. Whenever you're doing a skin exam, you want to examine the entire body. You want to have good lighting. You sometimes will need a Woods lamp if you're going to look for certain problems with the skin, certain etiologic agents. You want to make sure that you've noted the location of the lesion, the type of lesion, the color, the pattern, and the distribution. And these are often important. We learned that with, say, atopic dermatitis, there's a very distinctive distribution of where the rash appears, and that changes based on the age of the child. So distribution is important for us to know. It helps us with diagnosis. And it is also helpful in follow-up appointments if the pattern or the distribution has changed or advanced. There are certain diagnostic studies that are used in assessment of the skin. They can include scrapings of the skin for microscopic examination. That's often done in diagnosing, say, tinea capitis. Sometimes we will culture a wound if there's drainage to assess for the specific organism to aid with treatment. And also biopsies can be done, usually not in primary care, or patch testing is usually done by a specialist. Just a review of the different types of lesions that we can see. It's good to familiarize ourselves with the correct terminology for what we're looking at. A macule is a flat lesion. A papule is a raised lesion. A nodule is a raised lesion that's firmer because it, as you can see in the slide, it's deeper into the layers of the skin. A vesicle has fluid within it. A blister is a more superficial vesicle with a very thin membrane covering it. A pustule is a vesicle that has pus inside of it. A wheal is a swollen area in the upper layer of the skin that's often seen in allergy. Wheals are what are also known as hives. Excoriations can be interruptions in the outer and second layer of the skin, and they tend to go into the skin as opposed to coming up above the skin. And a fissure is a crack in the skin, and those can be very painful. Here is some pictures of different types of rashes and the terminology that's associated with them. So for example, a target lesion, it looks like it's like a bullseye. It looks like a target. And in the picture, you can see that this is actually what looks to be erythema multiforme, which is often a significant drug reaction. The middle picture, the linear lesions, this is an example of a contact dermatitis that's likely the result of poison ivy. The rash from poison ivy becomes linear because what happens is the oil on the skin, which causes a reaction and causes scratching, as the child scratches themselves, they scratch the oil into the skin, and the lines are the reaction to the oil being scratched into the skin. So a linear pattern is a very classic type of distribution, which helps make the diagnosis of poison ivy. The upper right-hand corner is a picture of an annular lesion, and annular is another term for a ring-like. So those are round, sort of ring appearance lesions. And the bottom right is a picture of lichenification, which you can see is a very thickened scaling of the skin, which sometimes happens in severe cases of eczema. Not only is it thickened, it's very rough, and it has like a chalky appearance. And then in the lower left corner, you'll see this rash, which is called a morbilliform rash. It's just sort of beefy pink and raised and fairly confluent. And this rash is typical of roseola and also measles. Now we're going to just talk briefly about some overall management strategies with dermatological disorders. One of the first things we're going to talk about is hydration and lubrication. So hydration is very important to protect the skin, to keep our skin in good condition so that it can maintain its function. And it also can sometimes be a treatment measure for when there is a lack of hydration in the skin. So skin that is optimally hydrated is soft and smooth, but water evaporates readily from the cutaneous surface, and that's even with intact skin. So when there's erosion of the top skin layer, that's even worse. Example of that is burns. So in a burn patient, the greater area of the body surface that's burned, fluid volume replacement becomes a huge problem in burn patients. But you can remember that any part of the skin that is eroded, is going to increase the fluid losses. As humidity falls in the environment, the stratum corneum, which is the horny layer of the skin, shrinks and cracks, and that epidermal barrier is lost. This can also lead to irritants entering the skin. So it's really important to maintain hydration, and to remember that in temperate climates like ours here in the Northeast, in the winter, there's a very little humidity in the air. It's a very, very dry air in the winter, and that's why many children suffer from excessively dry skin. So, children that have eczema sort of have dry skin all the time, but even children without eczema will have particularly dry skin in the winter, and then this can lead to interruption in the integrity of the skin, which could lead to foreign substances entering, infection, etc. The opposite of having dry skin is having overly moist skin. And when there's overhydration of the skin, then that can lead to maceration. And we sometimes see that in diaper areas, or in the axilla, or in the neck folds, especially in babies. So just in terms of dressings, I apologize for the way the slide appears and the way the words are showing up there. I didn't catch that, but a wet dressing. The purpose of a wet dressing serves several purposes, but in particularly eroded lesions that need to be occluded. A wet dressing provides moisture, moisturizes the skin, and then as the wetness in that dressing evaporates, it actually provides relief. So it sort of cools the skin and relieves itching. And so wet dressings are generally used in open wounds or weeping wounds to help dry them out. Occlusive dressings are going to decrease water evaporation. So if a wound or an area of the skin is completely occluded with a dressing, you need to think about if there's any medication that's put underneath that. It's going to increase the absorption of that medication. And in terms of hydration and lubrication, things such as irritating substances like wool should be avoided. Sweat, saliva are going to be irritants. We see saliva as an irritant in babies that drool a lot. They can sometimes develop a dermatitis around their mouth just from the saliva. And that there are certain foods that can be irritating to the skin as well and can demonstrate skin signs if there's an allergy to those foods. In terms of sunscreens and sunblocks, it is important for us to remember to talk to our patients about using those, especially in the summer months. That we usually do not recommend that these be applied to infants less than 6 months old, again, because of the thin outer layer of the skin and the increased absorption. And we should remind parents that sunscreens should not be considered a substitute for sun protection, like umbrellas and hoods and hats and long sleeves and other ways to protect the skin. We talk about medications for the skin. In general, topical medications are used whenever possible because there'll be less side effects and you're treating right at the site. We often want to restore hydration to the skin. We want to alleviate whatever symptoms are there. If they're itching, if there's itchiness or pain, we have medications that can be applied topically to reduce inflammation, such as topical steroids. We sometimes provide medications to protect the skin, to reduce scales, to clean the skin, or to eradicate organisms. We need to think in terms of how anything that is applied to the skin is prepared. If there are perfumes, for example, certain lotions or creams that are popular used in the newborn period, for example, Johnson's baby lotion, everybody loves it, it smells wonderful, but there is, a perfume in it, and for some baby's skin it's too strong, and so we need to be thinking in terms of that. If there's rashes that are appearing, especially in young infants, we need to be, checking out what types of lotions or creams parents are using. And that's pretty much it for that one. Other types of medications include antibacterial agents, certain things to keep in mind. In most cases, regular old-fashioned soap is good enough. We don't necessarily have to use antibacterial soap to clean the skin or clean a wound. We try to stay away from topical application of neomycin because it's high association with allergies. So instead of triple antibiotic ointment, we usually recommend just plain bacitracin. Sometimes oral antibiotics are used for skin infections, so we don't always treat topically. We sometimes need to treat systemically. I'm going to review when that's indicated. And if MRSA is suspected, if there's something that can be cultured, you will try to do that. Sometimes there is not any type of drainage to culture, so you want to think in terms of, where the infection could have originated, more the, social history, if the child's athletic, is there sharing of um, athletic equipment or gear, what the sort of rates of MRSA are in the area, if they've had previous skin infections, etc. And then we'll talk specifically about antifungal agents. We talk about fungal infections. There are antiviral agents that are used and anti-acne agents, which we'll hear about in one of today's presentations. Anti-inflammatory agents include topical glucocorticoids, and you want to remember to use the lowest potency that's effective, because there are side effects with the use of steroids, so we need to be cautious with that. Think in terms of the vehicle that the medication is in. Ointments tend to stay in place on the skin, so there's a higher absorption of the medication. Creams rub into the skin, and then they sort of, evaporate a little bit. So they once they've rubbed in, they don't increase in terms of absorption. But with the ointment, they sort of, it's thicker, and there's a higher absorption of medication with an ointment. Lotions are generally used in areas that when you have to cover more of an area, or on the scalp where there's hair. And we only use low potency steroids on the face or in any area that is occluded in any way, like the buttocks. On anything under a diaper, we would use only low potency steroid, and in the axilla. Antihistamines are often used to relieve itching, because a lot of skin problems lead to itching, and we only use oral antihistamines. We do not use topical antihistamines because they're associated with sensitization. There are some other types of agents known as calcineurin inhibitors, which we talked a little bit about, that are used in atopic dermatitis, but they do not have FDA approval for children under 2 years, and they are not first-line treatment. We're going to talk a little about scabicides and pediculicides, and hair and scalp preparations. Now we're moving on to bacterial infections of the skin and subcutaneous tissue. And a common infection that we see in pediatrics is impetigo. This picture is a classic presentation. It's often on the face, nose and mouth area. It's very contagious. It's caused by either group-based strep or Staph aureus, and it can be a methicillin-resistant Staph aureus. Treatment should include agents effective against staph and strep. If the infection is localized and easy to treat topically, we will use generally topical mupirocin, which is also known as Bactroban cream, and that covers both staph and strep. If it's difficult to treat orally because of the location, or if it's too widespread, then we will treat with an oral cephalosporin that can cover both, or like an augmentin. Bullous impetigo is not nearly as common in children. You can see why it's called bullous impetigo. There are bullae there. You can culture the fluid from the blister. An area where this can be seen is in the diaper area. And in this case, the treatment would be an oral antibiotic with staph coverage and cool compresses also. You want to make sure, I don't know where the picture went here, that impetigo complications from inadequately treated impetigo can lead to cellulitis, and other more significant skin infections. And we want to make sure parents know about hygiene and keeping the skin clean to prevent skin infection. Cellulitis is a more serious skin infection. It's a bacterial infection that goes deeper into the layers of the dermis and the subcutaneous layer. Cellulitis can be seen periorbitally and other areas of the skin, of the body. Strep pneumoniae and Staph aureus are the most common organisms. Usually clinically, there's been a history of a previous skin disruption at the site. It could have been an insect bite or a wound from a fall or a scrape. The area becomes more red, more painful, indurated, very warm. There can be a bluish or purplish tinge to the skin, and if that is present, then usually the offending organism is H. flu. You want to check for regional lymphadenopathy in the area, which would help confirm your diagnosis. Erysipelas is a type of infection that the skin is super bright red with very sharp margins. Most of these types of infections are going to be treated empirically there usually isn't anything to culture because the infection is deeper in the skin. And if the child is well appearing, you can treat orally and follow up in a day. If the child is ill in any way, then they should be treated inpatient. Here's a picture of cellulitis. And you can see how red the skin is. There appears to be an area of induration. It looks like there is one location where it could have been the original break in the skin that led to the spread of the infection. And you can see that it looks very angry. That's an angry looking limb. And what you would want to do if you were treating outpatient is you would mark the skin with a pen to where the border of the redness ends so that you can look for resolution on a follow-up appointment. And also you can let the parents know that if the redness extends beyond the pen mark that they would go to the hospital, which is, if I treat cellulitis outpatient, I will mark the area, but I will say to them, start them on antibiotics, and I'll say, it should start to improve, but if it's going in the other direction and the redness is spreading beyond the pen line, then just go right to the ER. And then we usually see them the next day, and then it's helpful to know that the redness has decreased. We are reassured that we're on the right treatment. You also, want to make sure that parents know that if the child becomes more ill systemically, develops a high fever or feels sick, appetite loss, malaise, then they should go into the hospital and it should be treated with IV therapy. Something else that you will sometimes see in pediatrics are folliculitis or furuncles. And a furuncle is a medical term for a boil. It's a bit of a deeper it's a superficial infection, but it goes deeper than just folliculitis. So sometimes there'll be a history of itchiness, tenderness. Some children are more prone to these than others. We see some children who get these repeatedly, usually in their buttocks. And the best treatment for these is warm soaks. And you shouldn't probe the area at all. You shouldn't pick at it or squeeze it, because that can actually cause the infection to spread deeper and lead to cellulitis. So just warm soaks until the boil breaks on its own. And depending on where it is, the age of the child, and how angry it looks, you can treat with oral antibiotics. However, they will sometimes, resolve on their own just with warm soaks. Moving on to fungal infections of the skin. So dermatophyte infections actually live on the top layer or superficial layer of the epidermis. They sort of live on top of the skin, and they can also involve the nails and the hair. Fungal etiology should be suspected with anything that's red and scaly. If the hair is involved, the treatment always needs to be systemic. And in this slide, you can see in the bottom left corner, there's a picture of tinea capitis, which is a dermatophyte infection of the scalp. And you'll notice that in that area, there is hair loss. This is a typical finding. And in addition to hair loss, with closer examination, you'll see broken hairs. And this is a classic way to differentiate fungal cause for the hair loss from other types of hair loss, such as in alopecia areata, where there is no broken hairs. There's just complete baldness in that area. So in tinea capitis, it's not completely bald in that area. There are broken hairs visible. And often there'll be scaling there as well. Another common finding is occipital lymphadenopathy. So definitely palpate for occipital lymph nodes. A culture should be taken. You can use a scalpel blade. I think it's a size 15 scalpel blade to scrape the crusts from the scalp into a culture tube and send it to the lab. But the culture does take time to come back. And as we said earlier, anytime the hair is involved with a fungal infection, you'll treat systemically. And we use griseofulvin. Griseofulvin, the book reviews the correct dosing, and it's better absorbed with fatty foods. So you can tell parents that they should give it with whole milk or ice cream or some other fatty food that will help with the absorption. The second picture is a picture of tinea versicolor, which is caused by a particular type of fungus. You can see these multiple discrete macules that are hypopigmented, and they become more apparent in the summer when they don't tan like the rest of the skin does. So treatment for tinea versicolor is selenium shampoo or ketoconazole shampoo. And your book goes into the details of how to do that. The last picture on the bottom right is a picture of tinea corporis, or what's commonly known as ringworm. And the classic presentation is an annular lesion, a ring-like lesion that's pink with an active border and central clearing. So as the ringworm progresses, it can get bigger. And often the skin within the circle, within that ring, becomes clear. So that's very classic. And the treatment for that is topical over-the-counter antifungals twice a day until resolution. This is a picture of a complication of tinea capitis known as a carry-on, which is a boggy collection of fluid underneath the area of alopecia. And so this carry-on should resolve with griseofulvin treatment. Okay, moving on to viral infections of the skin. First one is herpes simplex. Herpes are painful grouped vesicles or erosions on a red base. They're contracted by direct contact with secretions or mucocutaneous lesions. Incubation period is from days to weeks. And with herpes type 1, usually we see this in children on the oral mucosa, sometimes in the pharynx or on the lips at the mucocutaneous junction. HSV type 2 can cause neonatal infection or a genital infection in sexually active teens. But both types can be found in all locations. Herpetic whitlow is a herpetic infection of the finger or thumb, and this can result from thumb sucking in children who have oral HSV. And whenever there's a HSV skin infection, this can be a lot worse in patients with eczema. If it's the first infection of herpes virus, then there are generally systemic signs: fever, malaise, sore throat, decreased fluid intake. In children who have herpes stomatitis, they do appear really, uncomfortable when they come in. They have lots of oral lesions, and herpes tends to be in the front of the mouth. So tip of the tongue, lips, inside the lips, gums. They can cause gum swelling, redness, even bleeding. They have submandibular lymphadenopathy, fever. They really look ill. And they often don't want to drink because their mouth hurts so much. As a rule, we just treat symptomatically with, fever reducer, ibuprofen, fluids, an oral anesthetic for comfort, which we usually tell parents to make themselves. It's Benadryl and kaopectate mixed together 1-to-1, and sort of apply it to the lesions with a Q-tip. We don't always, we don't tend to give acyclovir in the younger children for this. It's not really indicated because it will resolve, on its own, and usually acyclovir only works, changes the course. It's not going to do much except maybe shorten the course of the illness, and you have to give it within the first 48 hours, or else it doesn't really have much effect. Another viral infection that we see in pediatrics fairly commonly is molluscum contagiosum. And this is a pox virus. This picture is a very classic picture. They're very, look just like this. They're flesh-colored papules, and they can look like there's fluid inside, and then they umbilicate, and then what protrudes from the umbilication is this sort of cheesy white substance that's really kind of funky looking. It looks like something is kind of growing out of them, and they're very unpleasant to look at, but they're benign. The problem with molluscum is that they can hang around for a long time, months and months, so parents don't like, seeing them there. The axilla, the chest, is a common area for them to appear. A child can have one or two, or they can have numerous. And the treatment, is kind of controversial. There's no consensus on what to use. There's lots of different treatments that have been suggested. Some of them are painful, and since it's a benign problem, it's sometimes hard to justify, inflicting pain to remove them. There's no evidence-based literature that demonstrates that one treatment is superior to anything else. So it's going to be a decision that will be made with the parent and perhaps a consulting dermatologist. You can check in your book. Your book lists all the different treatments that are used, but the Imiquid seems to be the most popular, but I do not believe that it has FDA approval for use for molluscum. So, and removing them is very painful. So, again, it's, something that you just have to work out with the family. Warts are very common. We see these a lot in kids. They're caused by the human papillomavirus. Usually there's an area of trauma, either a small cut or scrape, and the virus enters the skin in that location. Once the virus is in the body, it sort of stays there. And warts can reappear in all different areas of the body. Most times they occur in the hands, the fingers. A lot of times I see them on kids' knees and on the feet. And they are, unpleasant to look at, especially if they're on the hands and they're on kids who are starting to be concerned about their body image. So we do want to treat them. However, there is no single effective treatment for warts. Watching is always, and waiting is always an option. They tend to recur. Even if you freeze them off, they'll come back somewhere else. We can not treat them, and sometimes you can tell patients to just wish them away, and they often will go away on their own. So the decision to treat them is based often on where they are, how many are there, if they're unpleasant or uncomfortable. You want to avoid harming the patient with the treatment or scarring the patient. Any warts found in the genital area should raise suspicion for sexual abuse and be referred. In your burns textbook, you can review box 37.6 for the different treatments that are recommended or that are suggested for warts. And you're going to encounter this definitely in primary care. Another thing you will encounter, unfortunately, in pediatric primary care is infestations of the skin. And one of the most common infestations is head lice, pediculosis capitis. Lice can affect different parts of the body, but in children we tend to see it on the scalp. In adolescents or sexually active adolescents, they can develop body lice or pubic lice. The adult female louse survives by sucking human blood, deposits 6 to 10 eggs per day on a glue-like substance about 4 millimeters from the scalp on the hair shaft in a waterproof shell. The nits incubate for about a week. They hatch and grow into adult lice over another 1 to 2 weeks, and they begin laying eggs. This picture is a pretty good picture of head lice. If you look above where the word pediculosis is, you can see those little clear, small, like almost sesame seed type things on the hair shaft. As the hair grows, they get further and further away from the scalp, and they stick to the hair. So the way you can differentiate them from dandruff is usually we take like a throat stick, tongue blade, and just sort of kind of part the hair with that. And when you see them, you just try to move them with the tongue blade, and they don't move. They really cling to the hair, and then you know that it's a nit. So pediculicides are the first line treatments. Permethrin is the first choice. There is some resistance to permethrin and permether. The other one, I forget what the name is. They're very similar names. They come from chrysanthemums, actually. And so then they're with these lice kits. They come little nit combs to remove the nits. It's a difficult process, but the pediculosis is not harmful to children, and children cannot be kept out of school for having head lice like they used to be. There has to be some environmental cleaning of the home to rid the house of the infestation. And so parents should be educated on that. Let's see. Treatment options are controversial. Like I said, lice are growing resistant to some of the commonly used treatment options. However, some of the prescription-based treatments are risky, such as malathion, which can be toxic and flammable. So again, a decision has to be made on whether to prescribe a treatment that has significant risks associated with it when the condition is not a health hazard. So these are some of the decisions that you will be making when you're out there working. And I will tell you that parents flip out when their kids have lice. And so you really have to be supportive and work together with them, because this can be something that really makes parents crazy. And so you sort of have to be available to them and provide them education and support them through this, even though this, again, is not a health concern. It's something that I've seen parents almost at their worst when they realize their child has had lice. So another infestation that you may see that I've seen a few times in kids is scabies. Scabies is the result of a mite burrowing into the epidermis, and this causes intense itching. The itching is usually worse at night. The scabies, the location of the scabies really depends on the age of the child. But in preschoolers and school age, it's usually between the fingers. In infants, it's often around the wrists and the ankles. There's a picture of the sort of burrows. You can sometimes see the little lines where the burrows underneath the skin. So you treat with a pediculicide, and sometimes also, in addition, you treat the itch with an oral antihistamine. And just let parents know that usually one treatment is curative, but the itch can persist beyond the treatment. And again, there are environmental issues that need to be taken into consideration as well with an infestation of this type. And we usually also treat family members because scabies are very contagious. So, and that's the end of this part one of your derm presentation. And if you have any questions, just let me know.